Hello everyone, my name is Polycarp, the International Medical Laboratory Scientist certified by the American Society for Clinical Pathology. So in today's video, we are going to discuss cardiac markers or markers of cardiac damage, markers of cardiac ischemia, cardiac angina, as well as heart attacks. What is cardiac ischemia? Cardiac ischemia can lead to activity related to chest pain, what is also called stable angina, or acute coronary syndrome or ACS. So stable angina predictably occur with a given amount of activity and resolve with rest, but acute coronary syndrome frequently occur unpredictably and it does not respond to cessation of activity. Acute coronary syndrome is then further classified as unstable angina or the more severe acute myocardial infarction, which mostly preceded by atherosclerosis, also known as a heart attack. Cardiac biomarkers are normally in the setting of unstable angina, but elevated in myocardial infarction as well. So the classical manifestation of cardiac ischemia is of course angina, which is also described as squeezing of the chest, heavy chest pressure, burning feeling, or difficulty in breathing. So this classic manifestation often radiates to the left shoulder, neck, or arm, and typically increases in intensity over a period of time and gets more worse or gets worse with either physical or psychological stress. So when someone is experiencing physical stress or psychological stress, this person would actually the intensity of this uh, manifestation will intensify. Non-classic symptoms also appears like more commonly expressed by women. Those include more stabbing, pulsating, or sharp chest pain, rather than the typical vice like pressure, nausea, shortness of breath, and abdominal pain. So, what are the cardiac markers in case of damage or markers of cardiac damage? So, the markers of cardiac damage, the first cardiac markers to be examined actually in clinical practice were glutamic oxaloacetic transaminase, lactic dehydrogenase, and malic dehydrogenase. But the first aspartic acid transaminase or AST became widely used in diagnosis of myocardial infarction. But because of the high false negative rate of this test, the labor intensive nature of the ACT assay, and also the short window of ACT elevation, the ACT was soon replaced by lactic acid dehydrogenase as the marker of choice, as it remains elevated for significantly longer period of time after myocardial infarction, up to 2 weeks. So, but because lactic acid dehydrogenase can be also elevated in various other conditions like cancer and anemia, this essay for isoform has overcome those pitfalls because specifically we have five isoforms of lactic acid dehydrogenase from LD or lactic acid dehydrogenase 1 to lactic acid dehydrogenase 5 and are found in human plasma. Lactic acid dehydrogenase is most abundant in myocardium as well as lactic acid 2 or isoform number 2. So we can simply say LD2 and LD5 is expressed mainly in the skeletal muscle and liver. The diagnosis of myocardial infarction was made by comparing LD1 and LD2 levels, but LD1 levels to surpass LD2 in myocardial infarction and the ratio remained elevated up to 2 weeks. So because LD1 is the most abundant in myocardium. That's why when someone is experiencing myocardial infarction, LD1 is likely to be elevated, and it will actually surpass LD2 in the case of myocardial infarction. So the next cardiac marker that should be tested for is creatine kinase. So creatine kinase was the next marker to gain favor, like lactic acid hydrogenase. Creatine kinase is also found nearly in all cells in the body, but high levels of creatine kinase are thus found in all muscle cells, in particular striated muscles. Damage to the muscles or brain results in rapid detectable increase in plasma CK at short times after muscle injury. But in a typical patient with acute myocardial infarction, serum CK levels are found to exceed the normal range within 8 hours, right? In typical cases, of course, of acute myocardial infarction, and to reach a peak of 2 to 10 folds normal by 24 hours, and then decline to the normal range after 3 to 4 days. So that is post myocardial infarction. Unfortunately, because of the ubiquitous expression of creatine kinase in all striated muscles, was a problem for specificity for CK as a marker for myocardial infarction. So, in spite of its sensitivity, this has been a problem because of the specificity. CK elevations were readily detected in conditions such as stroke, pulmonary disease, and chronic alcoholism as well, and after strenuous exercise. This obstacle was initially overcome through the discovery that CK exists in three cytoplasmic isozymes. So the three cytoplasmic isozymes of creatine kinase, it is M, B, and MM. So we have M for muscle and B for brain, and dimers of 2M subunits are also available. We have CKMM and CKMB, BB, of course, as for the B subunit, and also another subunit with one M and one B, which is CKBMB, which is, of course, creatine kinase MB. Elevated plasma levels of CKMM or CKBB can be found after injury to the muscle or brain, respectively. So the CKMM is found when there is injury to the muscle, and CKBB is found when there is injury to the brain. While CKMB was shown to be highly specific for myocardial damage. Example, of course, myocardial infarction. Additionally, elevations in serum CKMB could be detected at 4 to 6 hours after the onset of myocardial infarction symptoms, but significantly less than 24 to 48 hours necessary to detect the peak of LDH in plasma. So, like its rapid rise post-myocardial infarction, CK-MB levels quickly drops to the baseline levels by 2 to 4 days post-myocardial infarction, compared with 10 to 14 days that lactic acid hydrogenase drops up to the baseline after myocardial infarction. So because of its higher specificity and its rapid elevation post-myocardial infarction, about, of course, 4 to 8 hours, CKMB was long considered the most reliable serum marker for myocardial infarction, and it is still widely used today. So, use of these three markers, aspartic acid transaminase, LDH or lactic acid dehydrogenase, and CK or creatine kinase was the cornerstone of post-myocardial fraction management for several decades. Each has its individual applications. CK for early presentation, LD for the late presentation, and aspartic acid or AST for the intermediate presentations. The last one is cardiac troponins. And what is cardiac troponins? Cardiac troponin is a complex of three: troponin T, troponin I, and troponin C. So troponins offer additional advantage due to the timing of their release, whereas CKMB levels elevate rapidly post myocardial infarction within 4 hours, but return to the baseline after 2 to 4 days. CKMB can thus only be used within a short window of time after suspected MI or myocardial infarction, because it elevates within 4 hours, but it returns to the baseline after 2 to 4 days. That is a very short window period of time as we suspect myocardial infarction. Conversely, lactic acid hydrogenase levels remain elevated up to 1 week, but they are not detectable until 24 to 48 hours. That's also another challenge uh, that possessed by LDH or lactic acid hydrogenase, because elevation will take long time, that is 24 hours to 48 hours, but it can remain elevated up to 1 week. But cardiac troponins, on the other hand, are detectable in plasma at 3 to 12 hours after myocardial injury, and peaking at 12 to 24 hours and remain elevated for more than 1 week. That is 8 to 12 to 21 days for TnT and 7 to 14 days for TnI. So cardiac troponins does offer the widest window for detection post myocardial infarction and with the highest sensitivity and specificity, just because of two reasons. One reason is that it elevates very early, like 3 to 12 hours, it can elevate, and it peaks at 12 hours to 24 days. So it means within 1 day of acute infraction, you'll be able to detect the peak of this cardiac marker. So, and you can see it also offer long period of time of elevation up to 21 days for TnT. Thank you so much for watching the video. This is the end of the video. You kindly subscribe and follow other videos that are coming soon. Thank you so much. God bless you.